Good evening, everyone. So, this is our continuation of classes on reproductive immunology. And this topic today we have chosen because yesterday we did a reproductive immunology OPD at Bangalore. And we saw so many patients who had come with this ANA report, and we thought, so this has to be spoken about, and also the practical relevance of doing the test, also the interpretation is very important. So today's class is about the ANA positive. So the number of cases that we are all seeing about the recurrent implantation failures and recurrent miscarriages. So the number of tests that people are doing, the gynecologists are doing, have also increased. So we see CDC matching, we see treatments like LIT being given left, right, and center. We see people on tacrolimus, we see people on HCQ for months together. So this is one. A test that is ANA, which is used quite frequently by all the gynecologists and also the reproductive medicine specialists and also the immunologists. So today we will hear whether it has any relevance in reproductive immunology, or whether it is just a hyped test, or whether we should really take that into consideration, or we can just ignore and stop doing the test. So over to Dr. Jay to throw some light on this topic, which I think is quite relevant in this time and age where reproductive immunology is gaining a lot of popularity and a lot of limelight on its own.
Yeah. So, hi everyone, and I will straight go to screen sharing. So, Arti madam and Shilpa madam, just let me know if you can see my screen, please.
Yeah.
Visible, no?
Yeah.
Okay, fine. So, guys, just one important thing about ANA. Okay. So, when we try to understand ANA as clinicians, we need to understand the meaning of this word. Okay. ANA stands for anti-nuclear antibody. Okay. Promised I will try and finish everything in 10 minutes, which we know has a nucleus. So anti-nuclear antibody means you are trying to detect an antibody against the nucleus. Very, very broad spectrum word. Okay. And because it is a very broad spectrum word, it is going to be elevated in all cases where autoimmune diseases are present, and simultaneously it will be elevated in all cases where there is an immunological pathology. Now this is your bottom line for this entire class understanding. So what we need to understand is that whenever we are trying to look at ANA, there could be some titers which is significant and some titers which is non-significant. So when you do an ANA test, all titers which are less than 1 is to 80, basically we need to start treatment when the titer is above 1 is to 160. This is your golden word. 1 is to 40, less than 1 is to 80. All these things is what you see very, very commonly. And when you see something like that, you should never ever get bothered that you know what you should do in a situation like this. Simultaneously, I also want to throw some very, very important light, because many, many, many people who are doing the ANA test, they will be getting a report in their hand, and this report is going to mention something called as speckled pattern. Understanding, and that is something which is it is such a common thing, and people think that, oh, it's a great thing which has been mentioned. It is absolutely incorrect. Just remember one thing: anti-nuclear splaying of the nucleus is going to be reported predominantly in 3 to 4 manners. Okay. One of the manners in which it is going to be reported is a standard homogeneous pattern. That's very, very common when patients are having SLE and lupus. Okay, this is basics, absolute basics I'm going down to. Second is speckled pattern. Speckled pattern is again seen in cases like, Sjogren syndrome, connective tissue disorders, and all these types of things. Then there are other patterns called as nucleolar patterns. Okay, just remember that nucleolar patterns are predominantly seen in something called as scleroderma. So when you see a speckled pattern, what does it really mean? It just indicates that you basically need to show your rheumatologist once. You need to rule out all these connective tissue disorders disorders, you need to rule out Sjogren's syndrome, right? Now, when you see these things, okay, the minute you see this report, 50% of the times we are so busy in our OPD that we don't understand anything. So let me give you a beautiful flow chart. Hopefully that flow chart will settle down many, many things. Okay. What to do when anti-nuclear antibody titers are 1 is to 40? What to do when it is 1 is to 80? What to do when it is 1 is to 160? So basically, more than 1 is to 160, less than 1 is to 80, and less than 1 is to 40. Okay. Now just remember this thing. When it is less than 1 is to 40, this is the word. Don't do anything. Okay. Because this is commonly seen. Very, very, very commonly seen. In fact, if you see this consistently, then remember Jay Mehta. Remember endometriosis. Okay. Endometriosis, low AMH, oophoreitis, autoimmune antibodies to the ovary, all these things can give rise to conditions like titers of anti-nuclear antibody less than 1 is to 40. Your golden answer is you should not be doing anything in that situation. Okay. 1 is to 80, less than 1 is to 80, what you should do. Now, less than 1 is to 80, just look at the division like this. Okay. If there is no past history, that means if the patient has come to you first time, no past history means no abortion in the past, no IVF failure in the past. Okay. Nothing has happened to the patient. In that type of situation, again, go back to this thing. Don't do anything. Okay. Will it settle down on its own? The answer is no. The answer to this is no. The answer to this is no. Less than 1 is to 80, but there is a past history of this important word. Unexplained infertility. Very important. Huh? Unexplained infertility. Or if there is presence of more than 2 abortions, or if there is more than 2 IVF cycles failed. Now, if you have this particular box which has come in front of you, okay, this box has come in front of you, that is when you actually go and do this. Remember this. You evaluate. Don't treat. The answer is you evaluate. And if it is more than 160, then what do? You evaluate. So now what do you evaluate? Correct. I have mentioned evaluate, but what should you evaluate in a situation like this? So guys, remember for this, the answer for evaluation is also very, very simple. How do you evaluate these patients? Look at this. Very simple. These are your tests. You look at when you start off with CBC, CRP. You look at TSH and you look at free T4. Along with this, you should look at lupus anticoagulant, anticardiolipin IgG, IgM, beta 2 glycoprotein, IgG, and IgM. Of course, along with this, if your primary evaluation has given rise to anything, okay, amongst this, that means you go ahead and treat. That means you can go and treat antithyroid antibodies, that is basically your anti-TPO antibodies, so you treat that. If it is lupus anticoagulant, anticardiolipin beta 2 glycoprotein, you go ahead and treat that. You may also get in this situation RA factor, which will be positive because it is often positive in this situation. You may get anti-CCP citrullin protein antibodies, which are positive, which are all demarcators of rheumatoid arthritis. If in case something like this happens, basically you have identified the cause for having anti-nuclear antibodies. So your simple answer is, after you have evaluated this entire box, you should simply treat the patient. Now, how do you treat the patient? So I will give you the protocol which I follow. I understand completely that everybody who is listening to this lecture is an absolute expert. But for a common man like me, I'm going to tell you what I normally do. So the minute I find this, I do this. I involve my physician. Okay. Now, once my physician gets involved inside the system, I know for sure that if in case the patient, I will just broadly divide this very, very quickly. If the patient is having anti-TPO, my answer is to do TSH correction, and TSH correction is going to be done by something called as thyroid monitoring. That means thyroid supplementation and replacement. If the patient is having lupus, anticoagulant, anticardiolipin, anti-beta 2 glycoprotein, protein C, protein S, okay, I'm using all those words, then the treatment for that is very, very simple. You give low molecular weight heparin to the patient and you give aspirin to the patient. Understanding? That is all that you are supposed to do to the patient. Then comes the third thing, which is again very, very important in all these things. If there is RA factor, simple. Go to rheumatologist. The rheumatologist is going to decide if the patient is going to require methotrexate because that is the standard drug for that, or he is going to require any other drug. We are not supposed to do anything as gynecologist. And finally, if there is any other autoimmune condition, if there is an autoimmune condition, you will be treating it in support with a physician or a nephrologist, because your nephrologist and physicians both will play a very important role in the management of anti-nuclear antibodies. Now, this finishes the first 10 minutes. Now, after I finish this first 10 minutes, there is going to be one more thing, okay, which is very, very important, which is point number 5. So I will draw point number 5 here for all of us. Let me just draw it up, okay? Point number 5 is here. Very important. Nothing came. Anti-nuclear antibody positive, but nothing came. Anti-TPO negative, all this is negative. RA factor negative, this is negative. So that means it is idiopathic anti-nuclear antibody rise. In this situation, what to do? Okay, so these are the guidelines. I will very, very quickly draw them. Just remember, if the patient has come to you primarily, that means with primary fertility, okay, if the patient has come to you with more than 2 abortions or more than 2 recurrent implantation failures, or if the patient has come to you to do standard IVF cycle, in primary infertility and in standard IVF cycle, if the titer in this situation, you are only supposed to treat if the titer is more than 1:80. Okay. That means if it is 1:160, 1:320, all these things you are supposed to treat all the patients. Now, how do you treat these patients? There is no rocket science in this. 3 standard drugs are available: HCQS plus Ecosprin plus Vizolone, that is prednisolone. Understanding? How long should you give HCQS? It has to be given in a standard dose of 200 to 400 milligram per day. You need to give it at least 2 months prior to planning for conception. How does it work? It is basically an immune stabilizer. Okay, just remember that much. Don't go into the details. How does Ecosprin work in ANA positivity? The answer is don't know. Okay. How does Vizolone work and what is the dose? Standard dosage is 10 milligram once in a day or 5 mg twice in a day. Sometimes you can extend it up to 20 milligrams in a day based on the situation after consulting your physician. How does it work? The answer is don't know. Okay. Standard. Can you continue HCQS in pregnancy? So the answer is yes. Can you continue it in breastfeeding? The answer is yes. Can you continue Ecosprin in pregnancy and breastfeeding? Answer is yes. Can you continue Vizolone? Answer is yes. But in Vizolone, most of the times our physician will recommend you to taper the dose. Understanding? He will not ask you to continue the dose. Now, after having understood all this janjat of anti-nuclear antibodies, if there is any take-home point which we have to take home, remember one thing. Let me come, because these days, since even people like me have started doing publications in life, so let me come to some guidelines, and these guidelines may be important for us to, apart from this flow chart, understand all these things. Okay, so when you try to look at guidelines, no guideline recommends any form of immune therapy in anti-nuclear antibody. So I'm going to give a referencing of Shree guidelines 2023, available for free download. Absolutely. So anybody can just download it. Shree guidelines 2023 for RPL. Okay. They do not recommend any form of immune therapy. That means the cocktail which we love to give, intralipid, IVIG, PLIT, or whatever, tacrolimus, thymosin alpha, nothing is recommended. That is because You already have a known cause. You can give all these time pass therapies, which are considered to be experimental therapies, only and only in those situations when ANA is also negative and still there is RPL. If anti-nuclear antibody is positive, that means some element of autoimmune factor is happening somewhere. You can't be giving immune therapy when you already have a known cause. Understanding? That's a very important learning point. The same thing is echoed by RCOG, but RCOG is pretty archaic. So they recommended something like this in 2011 and 2013 if you go through their guidelines. The same thing has also been recommended by ACOG. In fact, ACOG considers all these therapies to be experimental, but then there is a bias of insurance and all these types of things which occurs when you try to look at these guidelines. But yes, these days people love to read, follow and cite guidelines, and I thought even I should start doing the same. Correct. What is it that we need to take home from a situation like this from our clinical perspective? What is it that we need to do? Guys, remember, ANA less than 1 is to 40, ignore. ANA less than 1 is to 80, ignore. Only evaluate ANA 1 is to 80 in situations where more than 2 abortions, more than 2 pregnancy losses have occurred, more than 2 IVF failures have occurred, patient is unexplained infertility more than 4 or 5 years. That is when you start evaluating. Any titer more than 1 is to 160 and above, just evaluate. If the evaluation protocol is positive, that means you found the diagnosis. Congratulations, go and treat that diagnosis, right? If there is lupus anticoagulant, the treatment is not to give LIT. It is stupidity to do LIT in lupus anticoagulant. Give ecosprin and give heparin. In fact, Sachin Dalal has joined here, so I remember this statement of Sachin Dalal long back. We are very dear friends, so he had once passed a beautiful statement. Rather than evaluating all these patients for all these blood investigations, which is going to cost me and my patient 25,000 rupees, if you evaluate all of this, I might as well give every patient ecosprin. Understanding? Yes, that may be correct in an Indian situation when the patient does not have money. But when we are talking of science and the logic behind it in today's time, I think if we put down pen on paper, then this should be how it should be. Any ANA titer positive in anything else, for example, anti-TPO positive, please go to a thyroid specialist or an endocrine specialist and they will treat it for you. Rheumatoid factor positive, send to a rheumatologist, he will give methotrexate, he may do whatever. If there is SLE positive, involve a nephrologist, he will give you the clearance, plan the pregnancy after that. The reason why I also spoke about pregnancy is because this triple drug cocktail, HCQS, ecosprin, Vizolone, is usually going to be started by all of us pre-pregnancy and usually going to be continued by all of us irrespective of the consequence for at least 12 to 18 weeks. Because we do this on a very standard basis in India, understanding, quite a lot of times we don't end up treating these disorders properly. Many a times none of this are required, just ecosprin and heparin would work. Okay, but then it comes down to individualization. And before I conclude, I want to tell you, no guidelines across the world in ANA positivity recommend any form of therapy like IVIG, intralipid, tacrolimus, thymosin, because that is a very important take home point. We often see, in fact, when myself and Shilpa madam were doing OPD this Sunday, we saw people in whom ANA positive was there and they have done 4 sittings of LIT. How will it work here? So be careful about all these things. I hope you guys enjoyed the flowchart. Shall be happy to answer your questions.
Yeah, this was, I think, one of those classes which really, went above our head at one point or the other, but it was excellent. And the important thing was like you quoting studies and you quoting Shree. I never thought I would see this day in my life. So
I'm
I'm
a changed
really,
man.
I know, I understand. And I'm very grateful to God for making you a changed man. So
Yeah.
it's excellent. I mean, I really felt that, I mean, it can't get clearer than this. And I think all of the gynecologists who are actually practicing should listen to this class not once, but I think at least 4 times to understand. Because yesterday itself, among those 30 odd patients that we saw, so much of confusion both in the patient's mind and also the way they were evaluated by their primary consultant.
In
So
fact, we sent all of them home, madam. We never
Exactly.
evaluated anybody. We told them that you require nothing, right?
Nothing. Yeah, yeah,
Yeah.
true, very true. And you charged also for saying that. So, but it was like, I mean, it is, I think it is, as a doctor, it is our responsibility to know what not to do nowadays than actually, like, going overboard and doing stuff. So I think, I mean, this is such a wonderful practical session on ANA. I don't think like majority of us even, like, think so much about it, but I think this can really make a difference in our practice. So I don't have any question because I think it was wonderful. So I will leave it to Dr. Aarti if she has any questions to ask.
Yeah, thanks, Shilpa. Jay, it was a brilliant class, and I just have two, three questions. You were very clear when to treat, when to ignore, and when to escalate and do further tests.
Yeah.
What about repeating ANA tests? Because we also see people repeating it every
I,
year,
I
every
I told
IVF.
you. So when it comes to repeating the ANA test, no ma'am, I will go with the highest possible titer. That means if one titer is 1 is to 160 and the other titer is 1 is to 40, then I will treat based on 1 is to 160.
Okay, okay. And there's also an association of ANA positivity, like you said, for RIF, RPL, unexplained infertility, to also refractory thin endometrium,
Absolutely correct.
right? So if the patient is not having RIF, RPL,
That is why one of the treatments for refractory thin endometrium when ANA positive is very simple. Do ovulation induction with letrozole. That means do modified natural cycle.
Jay got
If
cut. No, no, can you repeat that?
do modified natural
Jay could
cycle.
not hear. You. Got cut. Can you repeat that?
Hello, can you hear me?
Yes.
If there is a situation of refractory thin endometrium, do modified natural cycle transfer in ANA positivity. That will give you a creamer of a result. Just try doing it once. The reason behind that is very simple. When you give external estrogen or when you give external progesterone to the patients, understanding there is going to be something called as estrogen and progesterone sensitization to anti-nuclear antibodies, and as a result of this the receptor action will go down, madam, because ultimately these receptors are also present on cells. Okay, and that is the problem. That is why you should give modified natural cycle. When you do modified natural cycle, we will produce a follicle. That follicle will go and act on those receptors. Somehow it will also produce 20 other molecules, relaxin, activin, VEGF, which we don't know what it produces, and it gives you a better outcome in the endometrium.
Okay. So how you do this immunomodulation for 2 months before we go ahead and plan treatment for RIF, RPL? Would you do the same for refractory thin endometrium
You will
before?
mandatory need, madam, 3 months. Though the guideline is saying 2 months, mandatory you will require 3 months, 100%.
Okay. And if a patient has high ANA titers and develops hyperstimulation, is
Yeah,
there any difference in your management during the
nothing much, ma'am.
IVF? What are you concerned about?
Nothing much. I'm not so much bothered about the clotting and all these types of things because I am going to be standardizing my protocols with letrozole so many times. So the estrogen value is going to be low only, ma'am, in most of the situations. But definitely in this situation, you can consider to add antagonist after your oocyte pickup is done. You can consider to add heparin also. No problem.
Okay. So that's it from my end. It was a brilliant class, Jay. And we just have one question. Someone asked, history of severe preeclampsia and IUD at 28 weeks. In the next pregnancy, will she require heparin, ecosprin, and even
If your
thyroid?
if your evaluation is positive for something, you might as well give it. Understanding? If your evaluation is not positive for something, correct, then the role of all these things is debatable because people who are on heparin will also develop preeclampsia. There is nothing that heparin prevents preeclampsia.
Hmm, true.
Yeah.
So I think we're done. Shilpa, from your
Yeah,
end?
that's it. Thank you keep for keeping it short. Great. Good night, all of you. Thank you.
Good night.